Center, Luke Messack, an emergency physician and historian at Brigham and Women's Hospital, an instructor at Harvard Medical School, who used to be based in Rhode Island. I got to know Luke through his first book, No More to Spend, which was about the intersection of global financial institutions' demands on developing countries, in this case Malawi, wasn't it? Yes. Yeah, Malawi, right. And basically sort of how it reverberates through healthcare. This is, of course, something we saw on the European side of the financial crisis, particularly in Greece, with cuts to healthcare expenditure being one of the de rigueur moves of the so-called troika. So once again, financial stability was more important than the health of the population, and one was cut to serve the other. Bonding over that, I said, why don't you come and give a talk? Because there aren't that many emergency room physicians who are historians. There are very few historians who can save your life. There's not. I know loads of historians. Any of them could save my life, but this one actually can. So it's very useful to know the one historian who can save your life. That's always a good one. This book, which I blurbed, I will just reread my own blurb on it because I loved it so much. Not my blurb, the book itself. Where's the blurb page? It's in here somewhere. This is it. The German word for debt is the same as the word for guilt, but you don't have to be German to be a guilty debtor in the United States, where the sin of being ill and poor is discharged by indenture labour and the harassment of the debt collector. Luke Messas takes us on a tour of the underbelly of America's hospitals and their horrific debt practices. If there's one country where you don't want to be both poor and ill, it's the United States. There's one story that Luke will probably talk about. The reason he ended up writing this book, I think, was because of an incident that happened when he was working in Rhode Island. And he had a couple of working class patients, and one was being treated. And he said, well, you should really do this, and you should do that, and do the next thing. And basically he said, well, I can't afford that. And it suddenly hit him that the advice he was giving was stunningly irrelevant to the lives of many people that he's trying to serve. So he started to look into what the hospital did, and he started to give advice to patients on how to basically deal with debt, etc. And the higher administrators basically pulled him into the office and said, what are you doing? You don't do this. And it's that reminder that at the end of the day, it might have non-profit on the title, but at the end of the day, they work very much like for-profit institutions. And if there are bills accrued, that is their income streams. Your liability is their asset, and they want their money back. With that, Luke, tell us about it.
Thank you, Mark. I've been inspired by Mark's work ever since I read Austerity, like a dozen years ago as a student, and I've been doing my best to do a pale shadow of a Mark Blythe impression since. But I'm so grateful you're here, and looking forward to hearing from you about what we can do about this problem. This is, as Mark said, the place where I trained, Rhode Island Hospital. I was here. I was basically locked in this hospital for 4 years, and 2 of those were during COVID. So I actually do. This is a sepia toned photo, and some of my memories are sepia toned. It was a hard place to work. It was a hard place to practice, simply by virtue of the work that needed to be done. But I'm so grateful for the people who taught me there. And should you ever find yourself in the emergency department, and you're not in too much pain to think about what else might be going on, just spare a thought for the folks working there, because they're working very hard. But it was there that I started this journey. And like Mark said, I'd had some patients who told me that they couldn't follow my advice, oftentimes to stay overnight or to get a certain test. And I'd ask them why, and they'd say, I can't afford it, or how much will it cost? And that's a question that we can almost never answer. And so, I'd always try to assuage their concerns. I would say things like, the hospital will work with you, surely, you have insurance, or, we can get you insurance, don't you worry about it. And I thought for sure that was decent advice. Sometimes I got a quizzical look back. But I thought I was doing right by my patients. And then I started to hear stories from Hopkins and a few other places about friends of mine who were protesting their own schools, protesting their own hospitals for suing patients. Oftentimes low-income patients, sometimes their own janitorial staff, low-income workers in their own hospitals, when they couldn't pay their bills. And I found that galling, and I thought, well, at least I'm not there. And so I just wanted to make sure. So I found myself, anyone know what this building is, actually? It's a Kent County courthouse. So for those of you who live in Kent County, nice and pretty building, actually. And you walk in, I asked to be led into the court records, which is this fluorescent lit room with just one. It looks like the set of Severance, basically. Like you're sitting in this room with one old computer, and you can type in the name of an institution or a person even, and find out if they've ever been in the court system. And I typed in my hospitals: Rhode Island, Miriam, Newport, Hasbro. Well, Hasbro is part of Rhode Island, but I found out that they were in fact suing patients. They were suing many patients, hundreds in that year alone. This was 2019 when I looked. And some of them were single mothers with working low-income jobs. Some of them were people living on disability income. Some of them were recent immigrants. And when they wrote back, when they had the wherewithal to do so, they pled their case. They asked for leniency. And some would get some in the form of maybe a payment plan that would have them paying back a single ED visit for the next 5, 6, 7 years. And if they didn't pay, they would pay double-digit interest or risk having their wages garnished. I had no idea this was going on. I didn't know what to make of it. And I was just overcome with kind of, I gotta say, shame. And so I wrote some op-eds in some local newspapers. I sent it to the Boston Globe, no interest. Providence Journal, no interest. Ended up sending it to Uprise, Rhode Island. You guys ever read that one? Yeah. And Steve Alquist was like, yeah, sure, we'll run this. And so I didn't think much would come of it, to be honest. I was like, who reads this but me and like the 5 lefties I know? Turns out it's actually more than you'd think. I was on a critical care transport shift taking a patient with chest pain from Newport to Rhode Island in an ambulance, and I got a text message from my program director, my boss, saying, we got to talk. It was the day I'd published the piece, and so Steve had published the piece, and so I got on a call with her, and she said, "Are you sure you're right?" And I said, yeah, I'm sure I'm right. Like, one thing history teaches you is to bring receipts, right? You always have footnotes, and you don't write it until you know it. So I was sure I was correct. And she said, well, okay, they're telling me you should take it down, but I don't think you should. And we'll look out for you. And I was always grateful to her for that. Because I did have to have a lot of meetings with C-suite staff, and they were none too happy with me. They told me that they were disappointed in me because I hadn't gone through the proper channels. Okay, fair enough. And then, but second, they were disappointed because I was incorrect. And I said, I don't know where you're getting this information, but I can send you the court records. Like, I have them. I have the names, the court numbers. And so that day, I sent them 200 cases that they had filed in that year. And they said, okay, we'll look into this. And 2 weeks later, the CFO wrote back to me, and she said, I'm ashamed to say we were suing patients, and we've cut our relationship with the third-party debt collector, who's this lawyer in East Greenwich, and we won't do it anymore. So I was grateful to hear that, but I was so confused. I didn't think she was lying to me, and I was like, why? How is it that the CFO of this hospital can claim that they don't know they're suing their own patients? And that sparked a wave of curiosity in me. I couldn't shake it. I said, am I being hoodwinked, or is there something going on here that has led us so far away from knowledge of our own patients' financial circumstances? And I think there has, and it's a story worth telling. So I tell it in my book, Your Money or Your Life, and this work has led me to like more standard research and health services journals, which you can read about as well if you want like a shorter version of this, which I'll give today, but also there's a piece in the New England Journal. And then last year I testified before Congress, before Bernie Sanders' committee, the HELP committee, when he was still chair of it. So there's a lot of interest in medical debt in the United States today and what we can do to solve it. But before we do, I think as we do, if we ever do, we should know how it got to be where it is today. I think it's worth remembering the origins of our hospitals. I mean, hospitals, nonprofit hospitals in the United States, or charity hospitals as they were often known, were founded often out of almshouses, by religious institutions, or by ethnic associations, or by wealthy donors. In our case, Rhode Island Hospital was founded by wealthy industrialists in the mid-19th century. And the goal was to have a home for the virtuous poor. I mean, this is not really like the shining, splendorous rhetoric you want to like put on your atrium walls. But it is something to remember next time you walk through, Goddard Memorial Park where he lived. But this was a place not for the incurables or the vicious or the degraded, but it was for the virtuous poor. Oftentimes you had to make an application or have people speak to your character to be led into these institutions. But if you could, then you would be provided care, and often without expectation of payment. In fact, the outpatient center at Rhode Island, the precursor to our emergency department, provided care free of charge until the Great Depression forced some budget cuts. Doctors who worked outside of hospitals often worried about their patients' ability to pay, or their willingness to pay, or even the ability of them to tell the difference. So they would get these pleas from their patients about whether or not they would pay their bills, and they would have to decide what to do with them. Would they sever the relationship? Would they put them on a payment plan? Would they cut the bill? Would they forgive the bill entirely? Would they take them to court? And this was a relationship that was personal, right? You and your doctor would make this decision. And this is something that is far cry from where we are today. We'll get there, but just remember that. It was a personal, fraught relationship between the doctor and patient about what would be done with the bill. In fact, so fraught that doctors would take to writing verse in medical journals about this decision and how much they hated it. Things started to change in the 20th century. You have the rise of the hospital as an institution, not only for the virtuous poor, but for the paying middle class and upper income patient who would seek the technologies and treatments available at hospitals, new x-rays, new antiseptic surgery, all sorts of things that would lead people, the non-poor, into America's hospitals. And eventually, the rise of health insurance changed things as well. In the mid-century, you have a fairly rapid decline in the number of uninsured patients with the passage of Medicare and Medicaid in the mid-60s. And with this change came a new argument from hospitals about their role as charity institutions, which is that they were no longer charity hospitals, that there was no longer a place for the charity hospital. When you had Medicaid covering the poor and Medicare covering the elderly and private insurance for the able-bodied, what use was there for charity? So in the mid-1950s, the IRS had a standard that said that hospitals had to spend on charity care to the extent of their financial ability. That was a standard that meant that if many hospitals didn't spend at least 5% of their revenue on charity care, they could stand and did stand to lose their tax exemption, which is, as you know, a huge deal. In the late 1960s, after the passage of Medicare and Medicaid, the American Hospital Association started making an argument that this was no longer necessary. They prevailed upon a young staff attorney at the IRS who agreed with them and rewrote the standard to what we have now, the community benefit standard, which has taken varied forms over the years, but in its initial form said that a hospital could retain its tax exemption without this strict charity care standard. They could justify it with an open ER, like anyone could come to the ER. They had to spend on community benefit, which is very broadly defined, including the training of residents, the building of new facilities, and all sorts of things you wouldn't associate with charity care. And the willingness to take paying patients, right? So that the standard had changed quite a lot. And for his work, the IRS lawyer who worked on that was hired by the AHA as their chief counsel. So medical debt became more and more an issue in the press. I mean, you see mentions of it earlier. Obviously, like in the 40s, you had Truman remembering being a young judge in Missouri, where my own great-grandfather had once appeared before him to argue that his assets were not $15, but $8. But he remembered people coming to him who weren't able to pay their medical bills. But it became more and more an issue in the press. In the early 70s, you had hearings like Ted Kennedy's hearings about universal health insurance. You had plans put forward by the Nixon administration. And in the press, you had stories, sometimes salacious stories, about what people would do when they were driven to despair over their medical debts. This is the story of Heinrich von George, who was a unemployed former insurance salesman whose own son early had undergone surgery for a congenital heart defect at Mass General Hospital. And when he became overwhelmed by bills and his own, including his medical bills, he told his wife he was going out to look for a job. He lived in Brockton, Mass. He was going out to look for a job, He drove to, I believe, Poughkeepsie, boarded a plane, and announced that he was strapped with a bomb and was hijacking the plane, demanded $200,000, which he got. When they landed, they took off again and landed again. This is kind of a D.B. Cooper situation, but D.B. Cooper got away, but this guy landed, ran with a flight attendant to a waiting car, and was shot dead by an FBI agent. He was actually not, he didn't have a bomb. It was just a bunch of empty canisters of water. But this is the kind of stories that you started to see in the press about what medical debt drove people to do. But really the clear delineation in this story happens in the early 80s. As I feel like every book is like, in the 80s happened. And this is one of those books. So the 80s brought a number of changes in the way that hospitals were reimbursed for medical care. Democrats and Republicans thought that we were spending too much in Medicare in particular, and Medicaid as well, and so the system of reimbursement changed drastically. And what you had was a payment to cost ratio. So the hospitals was, a 1 is basically what the hospital would claim they're breaking even on a patient, right? But Medicare was already, by their calculations, a loss-making proposition in 1980. By 1990, was much more so. Medicaid, even more so, 0.91 to 0.80 with the new method of reimbursement. Not only that, but the number of people enrolled in Medicaid, the program for the poor, decreased pretty precipitously in the 1980s as states were allowed to formulate much more strict eligibility criteria. So as the number of people living below poverty grew in the United States, the number of Medicaid recipients fell. So what does that leave? Hospitals are losing money on Medicare, losing money on Medicaid, and more people are uninsured entirely. So hospitals' uncompensated care costs went up. Who faces those costs the most? It's the public hospitals, right? We don't even have that many left, in part because of this era. 10% of hospitals in the country closed during this decade, and a lot of public hospitals were bought out by now for-profit institutions. So this was an era of much carnage in the hospital sector. What happened as a result of this? Well, one of the most visible effects of this in the emergency departments was patient dumping. And what this was basically you go to a hospital, and a private hospital, not nonprofit or for-profit, you check in and they do a wallet biopsy. They look at your insurance status, they ask you how much money you have, and if you don't have enough, you get shipped off. They put you in an ambulance and they ship you off to the public hospital nearby. Now patients were being shipped off in extremis, right? Gunshot victims, women in active labor. And this was a national disgrace. Stories appeared in Chicago and LA and in San Francisco. And Pete Stark, who is a Democrat from the Oakland area, pushed forward a bill called EMTALA, the Emergency Medical Treatment and Active Labor Act, which said that hospitals had to provide a screening exam when you present to an emergency department. And if you are unstable, they have to stabilize you. Now, they can charge you for that care, but they have to stabilize you. Hospitals didn't receive extra money for this. This was basically an unfunded mandate that was signed in the 1986 omnibus budget bill. And it has changed medical care in emergency departments for the better. I mean, we don't see nearly as much patient dumping. You have to, every time I transfer a patient, I have to sign, my life away to this form that says I'm doing it for legitimate medical reasons and not because I just don't want a poor patient in my ED. But so that has changed. But that's the extent of our threadbare right to health, right? So it did change things for the patients presenting the EDs, but it left hospitals with even more obligations to pay. So what do they do in response, right? You have this system where more and more patients are uninsured. Medicare and Medicaid are loss-making propositions. Some hospitals do things like trying to optimize their payer mix. I mean, everyone does this, right? You see the billboards on the sides of the street basically begging insured patients to present to the hospital because those are the patients that you make money off of. And so specifically privately insured patients. But what are you going to do with the rest of the patients who show up to your door? And what are you going to do with their debts? Well, some hospitals started to buy into the swan song of debt collectors who were coming to their doors, selling their wares and saying, let us take this off your hands, right? You guys have your revenue cycle management folks, your billing office. But you guys, hospital billing offices are built for one thing, to fight with insurance companies, right? That is their job. I wish them well in it. It's a hard job. And they're trying to maximize the reimbursements from insurance companies. They don't like calling individual patients. It's a hard job. It's dispiriting and soul destroying, and they know that, and so they don't. The people who work in those offices don't like to do it, and so they were willing to hear this pitch from debt collectors, and many more of them would do it. You see public hospital CFOs saying we're not gonna wait around for our money. We're gonna sell the paper. Right? They're gonna sell the debt to the debt collectors, and you see the rise of a lot of public and private companies buying debt. Cargill, which is known for grain dealing, is buying $7 billion in medical debt in the mid-2000s. Encore Capital secures $200 million from a bunch of banks to enter the distressed consumer space, which means buying consumer debt, including medical debt. This was big business and getting bigger. What does that mean for patients? Well, this is Quentin White. Quentin White was a retired when the time this picture was taken in 2003, he was a retired dry cleaning worker. His wife had sought care at Yale New Haven Hospital, another great hospital, in 1983, related to a cancer diagnosis. She'd been hospitalized twice. During those hospitalizations, she'd accrued bills of $16,000. Now, Quentin and his wife, who died 10 years later, had been working to repay this bill for 20 years. He had repaid in installments the entire thing. At the end of 20 years in 2003, he owed $40,000. Magic of interest. So he had his bank account drained by the hospital. He had a lien put on his home, and he worried about losing it entirely. He was living, he was in poor health himself, on dialysis, and he just thought he was going to die with these debts. When Lucette Nagnato from the Wall Street Journal showed up and started profiling his story and the story of other people. Now, it wasn't really, Nagnato wrote an amazing series on this. It's just incredible. But she actually didn't realize this. She wasn't the first one to realize this. The first one was, I just want to put in a plug for a dying institution. It sounds like the soundtrack to my life. A plug for a dying institution, the New Haven Advocate, or remember those weeklies, those alt weeklies that used to pick up by the side of the road. They were free, and they had some ads in the back, but they would profile local happenings. Well, this was one of those. Paul Bass in the New Haven Advocate was the first person to write about Yale New Haven's practices. Also taken up by a recent Yale graduate working for the SEIU, whose own members were being sued. So. This was really like a local action that became a national phenomenon. It ended up triggering a bunch of congressional hearings and changes from hospitals around the country in terms of their debt collection practices. But it was, this was the beginning of our understanding of as a nation of how aggressive hospital debt collection could be. It hasn't ended, though. So what does it look like? What does the debt collection process look like? Well, there's basically three different ways your debt can go. There's the hospital's own internal collections. And so, think of it, before the 1980s, the hospital's own internal collections department would sit on these debts for years, even decades. And they would just say, we're a public or non-profit hospital. It's not our job to chase patients around. We'll send them a letter, we'll give them a phone call, but if they can't pay, they can't pay. That's not the case everywhere always, but it's that's a general rule that a lot of CFOs said they followed. By the 1980s, 1990s, those internal collections departments became more aggressive, but they also sought the help of debt collection agencies. And you can work with them in two ways. One is to work on them on a contingency basis. So you assign the debt to them. You still hold the debt as the hospital, but you assign the debt to the debt collection agency. They collect on a contingency basis. They collect somewhere between 10 and 25% of what they are able to recoup from the debtor, and then the rest reverts to the hospital. Or you can sell the debt outright. So you can sell it to debt buyers. And this is pretty cheap debt as it goes. I mean, these are low-income patients whose debt has been worked already. They've been called, they've been written letters to, they've been threatened. Sometimes the court action has been taken against them. And so, you can imagine that these folks, if they could pay, they probably would, and they can't. So no matter how much money is on the bill, you're probably not going to get that much out of them. So the debt actually doesn't sell for that much. This is John Oliver. I don't know if you guys watched Last Week Tonight. He's been around for forever now. But in 2016, he did a whole episode on medical debt collection. And at the end of the episode, he said he was going to do the biggest TV giveaway in history. the previous record was Oprah's "You Get a Car, You Get a Car," that situation. Well, he said that was like $3 million in Nissan Sentras or whatever it was. But he was going to give away $15 million specifically in medical debt by purchasing it and forgiving it. This was a tactic that had been pioneered by members of the Occupy Wall Street movement and then by a few former debt collectors. But he worked with them to purchase and forgive medical debt from Texas. Now, this was $15 million in debt. How much did he pay for it? Or did HBO pay for it? Any guesses?
20 grand.
Damn. Recently, everyone's under-guessing. I think I'm overselling. It was, somewhere between the two. It was 60,000. So great guesses. Half a penny on the dollar about. But as you know, to think about that though, right? Think about that. So you're a hospital, you're selling debt, and you're seeking to, make up losses, but you're getting $60,000 for $15 million. So like, how much is that actually worth? Think about that for a second. Okay, so you have 6,300 debt collection firms around the country. Yes.
So I have a question. When a hospital sells its debt, are they also writing off the difference between what they sold the debt for and the full bill charges? And so in some sense, they're getting a spread on both the write-off as well as any potential, revenues that they can get.
Yeah, I don't know, actually. That's a good question. I should figure that out. I don't. So the debt collection firm. So there's a universe of debt collection that I entered in the last few years, which is an interesting world, and really nice people actually willing to talk to you, which I didn't expect. But 6,300 debt collection firms in the United States. Most of them are small, some even fly-by-night operations. Some of them are large, huge, publicly traded institutions. But the majority collect medical debt. For about a third of them, medical debt is the majority of their revenues. And working, just a word about working at these places. Imagine being a debt collector. And I just think this is one of those stories I think needs to be told more. There's a couple movies about debt collectors, but I feel like there needs to be more because it's hard for me to imagine a more dismal existence. I mean, you're making hundreds of phone calls a day to people who cannot pay their medical bills. And you're using a predictive dialer that makes the next phone call before you finish the last one. And you're just working and working these calls. And some of the stories are just horrific, threats and all sorts of put downs that some of the debt collectors do. But some of them, even if they're trying to be decent, it's still dismal work. And as a result, you see an annual turnover rate in these call centers, U.S. call centers, Indian call centers, in the Philippines, Central America, Caribbean. You see turnover rates between 75 and 100%. Patients in the U.S., the entry-level salary is about $11 below the median salary. And so, it's hard to imagine a harder work.
They be paid on a commission basis?
Yes, many of them are. So some of them, I've seen arrangements where you get up to 25% of what you're able to collect. So yes, a lot of them are being paid on commissions as well. But there's poor folks collecting from poor folks, but there's also very rich folks. And a word about a few of them. I mean, one of the groups I profile in the book is NCO Group, which is this group started in a garage right outside Philadelphia that grew into the largest medical debt collection company in the world, and mostly did it on the backs of medical debt. One of the guys who started it, Chuck Pioli, calls himself the king of cold calls, and he would basically wander the medical offices of Philadelphia, just selling his wares and promising to collect, and was very successful in doing so. In 2014, their outfit was sold to Platinum Equity, a firm owned by Tom Gores, 424th richest man on Forbes' list in the world, and the owner of the Detroit Pistons, a board member at multiple hospitals in Detroit and LA, a fixture of those communities. So these are really, really powerful folks who are involved in debt collection, including Tom Reed on the right, a former Republican congressman from Western New York, from Corning, New York, who made his money suing his constituents on behalf of the local hospital, continued to do so when he was in the House, which is not allowed, and eventually was brought down by a Me Too scandal, but is now a lobbyist. But these folks are very powerful. Yeah. But what happens to the patients, right? Okay, so there's the debt collection industry, shed a tear for the folks collecting it. But like what happens if you are sued? The civil courts are like not well covered in the literature. It seems like the lawyers like kind of don't focus as much on it in the legal journals. You'll see some articles, but like it's not very prestigious to write about them. So the best writing I've seen is from sociologists and a few like public interest lawyers. But there's many things that can befall you if you find yourself in the crosshairs. The first, you can have your debt reported to a credit bureau. That has started to cease with some actions by the CFPB and by credit reporting agencies. But worse things can happen to you. So the first is you lose your case by default, which almost all people do, and the hospital or the debt collector starts garnishing your wages. The major reason in the United States why wages are garnished is for alimony payments or for child support. Thank you, child support. But one of the major reasons is for medical debt. Up to 25% of your take-home pay can be garnished for a number of years to pay off a single bill. Second is bank execution. This is what happened to Quentin White. So they take your bank account, they drain it, becomes their bank account. Property lien. So a claim on your property can be placed. If they want to, they can then foreclose on your property. In the early 2000s, Yale New Haven Hospital and Yale School of Medicine had liens on almost 10% of owner-occupied homes in the city of New Haven. And this isn't that unusual. Like my mother used to work for the state of New York as an accountant, and one of her friends was involved in like the public hospital system. And they said, I love your book. All we did was place property liens on like everyone's home who owed money to the public hospitals. And I said, really, like that, that was, it just seemed, it's very common. And then probably the most surprising to me was body attachment. So debtor prisons are illegal and unconstitutional in the United States. You cannot be imprisoned for debt per se. But if you do not show up to the hearing at which your assets are to be determined, then you can be arrested and often are arrested for contempt of court. So people are in jail for medical debt. The ACLU wrote an amazing report on this called A Pound of Flesh, and they profiled the case of a man named Rex in Utah who missed a hearing after not paying an ambulance bill. And sheriff shows up to his home. His parents had just died. He was distraught. Takes him to the county jail, puts him in a cell. 2 hours later shows up and checks on him, and he's dead. And he had died of strychnine poisoning and killed himself. And so like this kind of thing can and still does happen. Some states have started to outlaw it, but it still does exist. Some great work by the Debt Collection Lab and January Advisors, a group of like PhD sociologists who have like the coolest alt-AC career I've ever seen, looking at the civil courts, found that most cases in the civil courts have to do with debt collection. Of those, this is in Oregon, by the way, of those, about a third deal with medical debt. Medical debt cases, this is in Minnesota, where you also have good records. Most cases are brought by the primary original creditor for medical debt. So that's right here, 72%. But about 30% are bought by the debt buyer. So think in this case, the original creditor can be the hospital itself or the physician's office itself or their debt collector working on an assignment basis. And then, as you'd expect, most of the people being sued are not like the rich folks who aren't paying their bills. They're low-income folks living in low-income areas. And what use is it to hospitals? I hadn't thought enough about the write-off question, but of what use is it to hospitals to continue to sue patients in this manner? Now, this was a paper written by a group at Hopkins, including Marty Makary, who's now Trump's CDC director, but has interesting views on medical debt. I wrote a book called The Price We Pay with 2 chapters on medical debt collection. And in this paper, they looked at Virginia and the suite of lawsuits filed there over the course of 1 year, and they found that many hospitals were suing patients and garnishing wages, but in those that did, they weren't collecting that much money. I mean, it was adding up to 0.1% of gross revenue for the hospital. in Rhode Island Hospital's case, if they'd collected on all the debt that they'd sued patients for, it'd be like a couple $100,000 in a year. That's if they were lucky and got everything. That's like the cost of less than, one doctor. So like it's not worth it, in my view, and in Macari's view, to continue to sue patients at this level. Now, why would they do it if it is not worth the squeeze? That was one of the major questions driving me, and that's one of the questions that I still don't have the best answer for. But one of the best came from a trial attorney named Dickie Scruggs. Dickie Scruggs is, anyone ever seen the movie The Insider with Al Pacino? No, it's like from the late 90s. It's like a noir thriller kind of thing. He was one of the, so Dickie Scruggs is based on him. He was one of the trial attorneys who helped bring down big tobacco in the 90s and big asbestos in the 80s. And in the 2000s, he tried to do it with big hospitals. So he basically started pulling together all these cases of hospitals not giving patients enough charity care and suing them on that basis and for aggressive debt collection. He lost almost all these class action lawsuits because there really was no right to charity care, as we covered in our IRS discussion. But he said, the way he described it in his Mississippi drawl, which I won't try to emulate, was you can't squeeze blood from a turnip, but you can keep that turnip from coming back, which is weird. I don't even know exactly what that means, but I think what he's trying to say is you can keep the low-income patients from coming back to the hospital, right? We saw an explicit statement in a few slides back of that sentiment, right? You are trying to maximize your payer mix. It makes a huge deal. I didn't realize how much. There's a great book by Colleen Grogan called Grow and Hide about healthcare spending in the United States over the course of history. And her point is basically like it's almost all publicly funded and we just hide it because it's privately captured. But she points out that a lot of the bonds that are used to fund hospital construction or hospital expansion, you look at all the atria walls in hospitals and you think that like all the expansions are funded by wealthy donors. Well, like kind of, not really. Like a lot of it is debt financed. But in order to get good terms on those bonds, the terms are dictated by the payer mix of the hospital. So if you have a lot of nice privately insured patients, then you get nice terms for your hospital construction, which is why the rich get richer and the poor get poorer, even in hospitals. So what can we do? This was a great paper published by a group of economists out of Harvard, Stanford, a few other places in 2021 using credit reporting data. Now, this data actually isn't going to be available to us that much longer thanks to some changes that make it less frequent to report medical debt to credit bureaus. But at the time between 2009 and 2020, this was very frequent that patients had their debt recorded to credit bureaus. And so you could get a heat map of medical debt in the United States, which is what this is, using that data. And as you can see, it's not evenly dispersed. It's highly concentrated in the Southeast and the Mountain West. It's also highly concentrated in low-income areas, as you might expect. Now, why is that? Why the Southeast and the Mountain West? Any ideas? Thoughts? Well, they come to a pretty convincing answer. And one is Medicaid expansion. Now, when the ACA passed, so much was made of the individual mandate. But the biggest part of that bill, the most significant part of that bill for most people in the United States, was not the individual mandate. It was Medicaid expansion. The expansion of Medicaid eligibility up to 133% of the federal poverty level, far, far higher than it had been in most states. Mostly funded by the federal government, a little bit by the states. Most states took the deal. By now, about 40 states have taken the deal. Originally about half now, but 40. Every couple of years, there'll be a referendum in a deep red state where the governor will say, hell no, and 80% of the populace will say, yes, please. So this has been really, really important. You see on the dark line is the flow of medical debt in states that expanded Medicaid in 2014, the first year you could. And you see that it fell by about half in those states. Now pay attention to the bar graph, this is 0.5, but it fell by about half in those states. In states that did not expand Medicaid, it stayed about the same. So this has been a hugely consequential change. As you can imagine, I'm quite nervous about changes in Medicaid funding passed by the House recently that would cut Medicaid pretty significantly and would lead to, one would expect, to a rebound in medical debt. This is a paper I wrote earlier this year showing that hospitals, in general, do side, you would hope, with the patients, but more often side with debt collectors in their in the federal decision making about what should be more firmly regulated. So credit reporting and telling debt in particular, hospitals wrote to the IRS to ask them to allow for less regulations. I'll finish with a few words about charity care or hospital financial assistance. This is this harkens back to the founding of these hospitals. What were they founded for? The care of the poor or the worthy poor. But hospitals today really vary in their commitment to that mission. The ACA states that every nonprofit hospital has to have a hospital financial assistance policy, which states the levels at which the hospital will provide free and or discounted care, usually stated as a percentage of the federal poverty level, which is about $30,000 for a family of four. And so hospitals will set their own levels. In some states there's a minimum, but hospitals will set their own levels. And as you can see, there's a pretty wide variation. For free care, which is the blue or greenish color, that is about 200% of the federal poverty level. So $60,000 for a family of four. But it can vary pretty widely. Some hospitals I've seen have 180%. $180,000 for a family of four, so that's 600% of the federal poverty level. Some hospitals don't provide free care at all, right, and only provide said discounted care. So it varies extremely widely. Now, on what basis does it vary? Well, there's not a ton of rhyme and reason to it, but as you might expect, areas with more poverty and higher rates of uninsurance have less generous financial assistance programs. Hospitals have started to come under fire when they don't provide enough financial assistance, when they hide financial assistance programs from patients or hire McKinsey to hide it for them, or when they sue patients aggressively. So this is something that's been coming up more in the news in the last few years. And with the start of the pandemic, you did see a decline in the number of lawsuits against patients and more attention to this issue, but whether that holds is deeply uncertain. And finally, what can be done? I think one of the biggest, easiest fixes to this is something called presumptive eligibility, which means that instead of making patients apply for financial assistance after their hospital visit and run through huge hoops in order to do so, involving fax machines and tons of paperwork, you can just enroll them at the point of care. You can use other state programs that patients might be enrolled in. You can ask them their income directly. You can use presumptive eligibility software that's provided by private entities. But there's ways to do this, and some hospitals like OHSU in Portland do this, that prevent patients from having to go through the rigmarole of applying. Just sign them up right away. And then these are some things I've been trying to, when I speak before hospital executives, I ask them to consider. Stop suing patients. It doesn't help, and it definitely harms your public relations. Expand eligibility for financial assistance, adopt presumptive eligibility, and work with states. We're entering an era where federal action is increasingly unlikely, but states have moved on this issue, red states and blue states. The most recently is North Carolina, which has an amazing program now, endorsed or signed up by every hospital in the state has signed up for this, which allows for presumptive eligibility in every hospital, as well as an end to many aggressive debt collection practices. So this is something that we can make some progress on even now. And so I'm really excited that we can continue to make progress, even as I'm scared for the future. But I'm so grateful you guys came and looking forward to hearing more from you. Thank you.
We're online, so we have the microphone, so you have to ask your questions through the microphone. I'm going to get started. How does personal bankruptcy fit into this? Because if somebody's coming, I've actually helped a couple of people with this in Rhode Island, that basically they couldn't pay the $1,500 bankruptcy fees. Yeah. So if you can get the $1,500, you can shield yourself. And there's a bunch of people that cooperate in doing this on a very ad hoc basis. Yeah. But it's obviously an inefficient way, but you can get yourself out of this if you do personal bankruptcy, right?
Yeah, you can. I mean, a lot of the personal, I kind of avoid personal bankruptcy in talking about this because it's become this like real bugaboo in the literature. Elizabeth Warren first started writing about this in the 90s and or actually earlier, about how frequently Americans end up bankrupt because of medical debt. And in their estimations, it was the leading cause of bankruptcy in the United States. Some economists say that's not quite true. Maybe it's, it's something that comes along with bankruptcy, but it's not the cause of bankruptcy. So I don't always talk about bankruptcy, but yes, you can get out of medical debt with bankruptcy, but that is a, pretty...
But the weird thing about it is that the other side of this is once you've gone bankrupt, right, there's this kind of moral stigma, et cetera, right? Literally in cases I know personally that we've helped through this process, 6 months later, they're getting credit card offers, right? Literally within 18 months, you're back at 650 on your credit score. Right. I mean, so basically, in a sense, why would you not do this? And I'm just wondering if it's kind of an information deficit as much as a financial hurdle, that they don't want you to know that you can actually do this. Because if you're facing $60,000 in debt, right, and you go bankrupt and you literally can get a car loan after 2 years, why would you not do this? Because the previous debt's discharged, can't come after you, wage garnishment, all that goes. Anyway, something to think about. Next up. Nobody. Right. Okay, we'll start with Tony and then we'll go here.
Yeah, I'm just curious about the economics of the collectors, and if they're buying it for pennies on the dollar, are they making their spread on exorbitant interest rates, and is that where the money is coming from?
Yeah, I mean, this is an interesting industry in that, like, it had its heyday kind of in the mid 2000s, but by the late 2000s, but like in the years after the financial crisis, and then even now, there's been like a lot of consolidation in the industry, and it's not quite as profitable as it used to be. So when you talk to a lot of these old hands at debt collection, they talk about like the glory days of the 90s and 2000s. A lot of the contingency rates have come down. So where hospitals used to pay like 25% contingency rates, now they pay 10%. And there's been a lot more competition in the space. So the competition is pretty fierce to make a buck out of this. And so as a result, they will tend to negotiate these prices pretty low with hospitals. But yeah, anything they're able to recoup from the debtor, they will keep. And so they'll often resort to pretty aggressive debt collection tactics, using litigation, using debt reporting, credit reporting, but they and as well as interest rates. So interest and court fees are often a part of patients' ultimate payments once they enter the legal system. But it's interesting. It's like not, they make you trying to feel bad for them when you talk to debt collectors. So like, it's not as easy as it used to be. It's actually quite hard, and we try to be decent. Like, we're not the ones, threatening patients' families over the phone. And like, well, who is? So, it's a very strange industry, mostly built around like personal relationships between the debt collector and hospitals. There've been some efforts to try to like routinize this, to build a market where where hospitals can put up their medical debt more easily, but it's still an industry built around personal relationships, the handshake, the cold call, the meeting at dinner to try to get hospitals to sell their debt.
This is just a point of information. Steve Elquist doesn't work for Uprise anymore, but he has his own blog,
Yes.
and it is footnoted, and it has recordings of everything he covers. He's wonderful.
Thank you. Yeah, I misstated that on a podcast once, and people were not happy with me.
Next. Don't be shy. The problem is he's giving you a complete talk, right? There's really nothing to ask. Because, like, yes, that's it, you've covered it. That's
Well, actually, let me say one more word about what can be done. So, yeah, I didn't mention this before, but these are 3 organizations that I'm part of tangentially and appreciate their work. The Debt Collective grew out of the work of Occupy Wall Street. They were some of the first people to buy and forgive medical debt. Now they've moved on to more like grassroots, kind of a wholesale critique of the debt industry. And they are kind of a debtors union is what they call themselves, a new model of what union organizing can do. Physicians for a National Health Program, PNHP, is a group basically founded out of that patient dumping era where physicians coming to realize that really the only answer to this is a single-payer healthcare system that's free at the point of care. And so there's always an opportunity to join that if you're a physician. And then the last one is the most pragmatic, which is $4. This is a group founded by a former bartender in Seattle or Washington State whose own family was in debt and realized through his work trying to raise money for people to pay off their debts, that hospital financial assistance exists. It's just hidden often and difficult to apply for. And so what he and his group do, I'm on the board of it now, they help patients apply for hospital financial assistance. They don't ask for a dime, but if you or if someone you know wants to see if they can qualify for hospital financial assistance, they have a tool that you can use to look at your specific hospital, see if you qualify for charity care at that hospital, and then they will help you apply without asking you for a dime. So it's a group I really believe in.
How should we think of debt collection as a kind of component in of itself, or just a broader piece of the financialization of hospitals that's really occurred over the last 2 or 3 decades? And so, debt collection, I think it's a lot of attention, but a bigger component is just, hospital prices have exploded over the last 2 decades, and hospitals are now, one of the hugest moneymakers across the entire U.S. economy.
Yeah. I mean, the story I try to tell in the book is a story of like increasing alienation of the physician from the debt collection practice, right? It used to be a personal relationship between doctor and patient. It's not a relationship I look forward to having ever, telling my patient to pay up. So in some part of me is grateful that that's not a part of my day-to-day existence, but blindness is not probably a solution either. But what's become of it is first you hand it over to the hospital to do the debt collection, then you hand it over to the debt collection on assignment, and then you hand it over to the debt buyer, for whom these patients are numbers on a sheet of paper, like the definition of financialization. So that is part of the story I'm trying to tell. But yeah, it is of a piece with a much larger turn in the literature and health economics and sociology about the financialization of healthcare, which demands that we understand much more about hospital finances if we're going to do anything about this. Like the Grogan book, I think, is really great in that it brings to the fore a lot of policy and financialization questions that just got almost no debate, when they were coming up. A lot of the mergers that happened in the 90s and the 2000s were driven in large part by the same kind of dynamics we talked about with bonds and payer mix. Like if you are a larger hospital system, you get better terms. And so that drives a lot of the mergers as well that drive up prices. Like it's all of a piece. And so this is but one small part, but it's the part that touches on my patients' lives and my lives maybe the most.
Great talk. Thank you very much. And it seems like it's so difficult to collect the debt from the poor patient, right? Mm. So why a hospital not adopt a model like ours progressive income tax, right? And so for charging patient, maybe you should have a regressive model based on the income, right? That's avoid a lot of future headaches.
Yeah, I mean, I think in theory we do have that with the financial assistance programs. With some patients qualify for free care altogether, and this is the thing that they brought up to me when I first met with the C-suite executives. They said we're proud of our financial assistance program, which is actually the one at Rhode Island is more generous than the one at Brigham where I work, which is nuts. But if you make I think it was it 200 or 300, I think it's 200% of the federal poverty level at Rhode Island. At least it was a couple of years ago. You get free care. And then up to 400%, you get discounted care on a sliding scale. And so that does exist already. But what we found is that billions of dollars are going unclaimed. About 14, by our recent estimates, $4 did a report on this, $14 billion a year in bills that shouldn't really have ever gone out are being charged to patients because they didn't successfully apply for financial assistance. So by putting the onus on patients, you make it so much harder to get the things that they're due.
How much of the debt collection is actually not targeted towards low income, but it's actually the kind of real focus is the privately insured patients, and essentially saying, if you don't pay this bill, we're going to ruin your life. And privately insured patients, end up doing that, and it's the low income patients who are kind of caught in the flack.
Yeah, I mean, we don't have great systematic data on this yet. The best we have is probably this kind of thing where they use the American Community Survey to try to see what zip codes do patients live in who are being sued, and what is the income level of those zip codes, or what is the there's one of the residents I'm working with went through the court records in Missouri and found the employers of patients who are being sued, and like disproportionately it's Walmart and Costco, and I doubt it's the executives at those companies. So like there's all this suggestive evidence, but not a whole lot of great like concrete data showing the actual income levels of the patients being sued. I mean, you also have the 2021 paper here, showing the income deciles of the places where patients live. So like what we can tell, and then there's the more impressionistic stories where people will walk into the courts being filled by patients and notice that like a ton of them wearing scrubs. Like this is in Memphis where this the private equity company that owned a physician staffing group of emergency physicians was suing patients in droves, and so you walk into the courtroom and a lot of them are filled with like janitors from the hospital. So there's all this suggestive evidence, but we could absolutely use more concrete data. This is like what I've been begging for money for to do more of. I got some funding from the Robert Wood Johnson Foundation to undertake it, but we need more data from the civil courts on debt collection practices and who they're being targeted against. But for a number of reasons related to digitization of records and hospitals kind of shielding themselves behind names of debt collection agencies, it's actually not that easy to know.
So it seems like debt collection is a bureaucracy, right?
Yeah.
Do you have any idea what the cost to the country for having the system exists?
Yeah.
Publicly, privately.
Yeah, I mean, there's always, if you go to PNHP, they have like a slide deck about like, administrative costs in the United States and how much it costs to maintain the system and collect from patients. The example that they'll always use, and this is one of the scholars I interview in the book, Steffi Woolhandler's husband, why is his name escaping me? Anyway, he's at Cambridge Health Alliance, and he points out, he went to, you go to a major American medical center, Mayo Clinic, Brigham, whatever, and you'll go to the billing office. It's just hundreds of people charged with either calling up patients or often insurance companies to try to get their bills. And he went to a hospital in Toronto, the largest private hospital in Toronto, and went to their billing office, and it was 3 people. And he asked them what they do, and they said they deal with the insurance companies from patients who come from America. So it's just we're it's all so dumb. But like I don't even bring up single payer that much anymore, even though I should. But like at the end of the day, like it's not even intellectually that interesting that's the answer, because it is. But it is. Yeah.
I think we'll call it quits. Thank you very much for a brilliant talk.
Thank you.